giving at times. We now present a compilation of these rare complications during vitreoretinal surgery and their management. This video demonstrates the subretinal migration of intraocular foreign body. After initial vitrectomy, a foreign body is noted close to the ora serrata with retinal break. The foreign body appeared to be stabbed in the choroid. After completing the vitrectomy, while examining the same area, the foreign body was not found. However, it had migrated subretinally under the macula. Subsequently, with the help of the magnet, the foreign body was steered through the peripheral retinal break and eventually through the sclerotomy. This video demonstrates the subretinal injection of brilliant blue dye during macular hole repair surgery. After completing the pars plana vitrectomy, fluid air exchange was done. Brilliant blue dye was injected, and here the subretinal dye was noted inferior nasally. After completing the ILM peeling, partial removal of the subretinal dye was performed using the flute needle. After air exchange, laser barrage was performed around the break. This video demonstrates the subretinal air migration during fluid air exchange in a case of an aphakic inferior bullous retinal detachment. After completing the vitrectomy, peripheral vitreous base excretion was done. Fluid air exchange was started, and here subretinal air migration was noted. In an attempt to remove the subretinal air, further migration was noticed. A repeat fluid air exchange also led to the same complication. Subsequently, heavy perfluorocarbon liquid was injected, which then also migrated subretinally. In suspicion of peripheral traction as a cause of subretinal air migration, 360 degrees of relaxant retinectomy is performed. Subretinal bands were removed. Retina was attached under heavy liquid. 360 degrees endolaser was performed at the edge of the retinectomy, and silicone oil is exchanged for heavy liquid. Successful retinal attachment was hence achieved. This video demonstrates suprachoroidal migration. Brilliant blue dye was injected, and here the subretinal dye was noted inferior on the break. This video demonstrates the subretinal air migration during fluid air exchange in a case of an aphakic inferior bullous retinal detachment. After completing the vitrectomy, peripheral vitreous base excretion was done. Fluid air exchange was started, and here subretinal air migration was noted. In an attempt to remove the subretinal air, further migration and silicone oil is exchanged for heavy liquid. Successful retinal attachment was hence achieved. This video demonstrates suprachoroidal migration.
In cases of compromised posterior capsule, a safe in-the-bag procedure is often challenging. A careful intraoperative assessment must be carried out with attention to the corneal clarity, presence of vitreous in anterior chamber, iris abnormalities, and adequacy of capsular support, which can be determined by gentle retraction of iris at multiple locations under OVD protection. Various compromised posterior capsule scenarios encountered by a surgeon can be grossly classified based on size of the posterior capsular rupture, intactness of capsulorhexis, adequacy of capsular support, and the status of iris tissue. When posterior capsular rupture is small, irregular, and centrally located with minimal vitreous loss, the irregular rupture can be converted into a posterior continuous curvilinear capsulorhexis, which renders the tear strong and resistant to peripheral extension, thereby making in-the-bag IOL implantation feasible. If posterior capsular tear is large and peripheral, either with intact capsulorhexis or compromised capsulorhexis with adequate capsular support, which is usually 3/4 or 9 clock hours of the anterior capsular rim, a 3-piece hydrophobic acrylic IOL can be placed in the ciliary sulcus. It is noteworthy to mention that a significant vitreous loss frequently accompanies this complication, and hence a meticulous anterior vitrectomy aided with triamcinolone will greatly assist in the placement and long-term stability of the IOL. The rigid and longer PMMA haptics provide better stability and are more biocompatible with uveal tissue. A single-piece hydrophobic acrylic IOL should be avoided in view of poor centration due to shorter overall length and flexible haptics. Furthermore, the thicker and sharp haptic margins may rub against the iris, causing pigment dispersion and secondary glaucoma, which is not the case with a 3-piece IOL where the posterior angulation of haptics keep the optic away from the iris. Moreover, placing the IOL in the ciliary sulcus would result in anterior shift of effective lens position. Therefore, the IOL power should be reduced by 1 diopter for an average sized eye. Furthermore, the IOL optic can be captured posterior to the rhexis margin to lock the IOL in its place, preventing against future decentration and eliminating the need for adjustment of IOL power for sulcus placed IOLs. If the capsular rhexis is compromised with inadequate capsular support, decision of IOL implantation would be governed by status of iris tissue support. When the iris tissue is intact and healthy, iris supported IOLs provide excellent outcomes. These are broadly of 2 types: iris fixated and iris sutured IOLs. Fixation of the IOL to the iris can be done using an iris claw lens and can be fixated to either the anterior or posterior iris surface. The IOL is inserted in the eye over the iris and rotated. The optic is then held with a forceps and positioned centrally behind the iris. The iris tissue is enclaved between the IOL claw haptics using special enclavation needles or a dialer. A superior peripheral iridectomy is usually performed to prevent pupillary block glaucoma. Iris fixation with sutures capture the optic of IOL anterior to iris, leaving the haptics behind. A 10-0 proline suture is passed through the paracentesis, through the iris, under the haptic and out through the iris again. Then, suture loop is retrieved out and the sliding knot is placed. Same is repeated for the other haptic and optic is then prolapsed posterior to the iris. On the other hand, when the iris tissue is deficient, IOL can be supported onto the sclera using various techniques. In transscleral fixation of IOL with sutures, 2 scleral flaps or Hoffman pockets are created 180 degrees apart. Using a 10-0 polypropylene or 7-0 Gore-Tex suture, a single piece PMMA IOL with eyelets is anchored to the sclera below the scleral flaps. In transscleral fixation with glue, a 3-piece foldable or rigid IOL is used, wherein the haptics are externalized through the scleral flaps and then tucked into the scleral pockets and secured using fibrin glue. Flanged intrascleral intraocular lens fixation, as described by Yamane, is a sutureless, glueless scleral fixation of IOL wherein an angled pars planar entry is made by a 30-gauge thin-walled needle. A 3-piece foldable IOL is injected using a cartridge and the haptic is externalized through the needle and cauterized to form a flange. The trailing haptic is externalized and then cauterized. The flange of haptics are pushed back into the scleral tunnels. When posterior chamber IOL implantation is not feasible, a properly sized and well-placed angle-supported anterior chamber IOL is a good option. To conclude, in compromised scenarios, a step-by-step approach while choosing the appropriate technique for IOL implantation can simplify the surgical outcome. We also emphasize the importance of good vitrectomy skills, watching videos, discussions with experts, supervised complication management, and practicing wet labs to improve confidence in managing complex intraoperative situations. forms a blob, it is very stable.
Yeah.
Actually, there has been one case which has been referred to our center where Yamania was done and then there was IOL which has completely tilted. So we had to remove it. But when you tried to remove, the flanges were so hard, we had to cut the haptics and then place another IOL. So it's very stable in that
I
way.
think it was a very wonderful video. Oh, did you observe, the long-term shape of the pupil as far as, these
Actually, now we are trying to do a long-term study. As of now, we have some 13 eyes, of which the long-term outcomes are good. The visual acuity, they have a little residual error around 0.5, 0.75, but the pupil is round and in that way it's good. Actually, it was a separate instrument, which is slightly a broader one. So the Sinsky hook or the dialer, it can perforate the iris. So there is a separate forceps from some company, I'm not sure. So that is so broad so that it doesn't perforate the iris and it's better.
That
Yeah,
actually
yeah.
to
There are
use
some
within
separate
the
hooks
iris.
also. Yeah.
So I do use these lenses also. They do very well. Okay.
Thank you.
Thank you.
So I'll be talking on, my apologies for the lack of voiceover due to some software issue. I'll be speaking over, I'll be talking over. So
No problem. Go ahead.
So this video is on tuck-in keratoplasty. It's a novel approach for conventional penetrating keratoplasty. So penetrating keratoplasty is a treatment of choice for chronic corneal decompensation. In majority of the cases, the visual recovery is prolonged and it is hampered by higher degrees of astigmatism. And suture removal gradually takes place over a period of 1 year, and there is more chance of wound adhesions. So this is a new technique which is an alternative to that. So this was a patient of 80-year-old female. She had a diminution of vision in the left eye. The reason was a chronic corneal decompensation in the left eye. The visual acuity was hand movements. The cornea was hazy. There was a thick central scar in the center, and the right eye of the same patient underwent a desec in our center because she had a sort of bullous keratopathy in that eye. And this is a clinical photograph showing the right eye showing a clear cornea with a desec graft in the center, the visual axis. The left eye, this is ASOCT showing the thick hypertrophic epithelium in superficial and thickened corneal stroma. Diagnosis of Fuchs dystrophy in both eyes was made. Right eye post desec and the left eye corneal decompensation. So we plan to do a penetrating keratoplasty with a new technique which is called tuck-in keratoplasty. So the advantage of this is the suture removal can be done as early as 6 to 7 months. The astigmatism is minimized and all the suture-related complications are minimized. So what we do is the corneal tissue is mounted on an artificial anterior chamber, and after injecting viscoelastic inside with a Hesburn Barrett refine, around 400 microns of trephination is done. Then a crescent blade is taken in the periphery of the wherever we have refined till the limbus. We create a pocket all around 360 degrees. Then the superficial ledge tissue is cut with the Vanna scissors, again all around 360 degrees. So this is the way the superficial flange is cut. Then with the MVR blade, the anterior chamber is entered at the one point at the limbus, and using a Vanna scissor, the cornea is cut all around 360 degrees at the limbus. So this trephination was around 8 millimeters in size, and the peripheral flange was around 10 millimeters. And the cornea is mounted on the Teflon block and viscoelastic is put, and that was a peripheral flange. And this is the patient's eye having a chronic corneal edema in the center. A Fleringa ring is put. Anterior chamber is entered with an MVR blade. Viscoelastic is injected into the anterior chamber. Then with the same Hesburn Barrett refine, which was around 7.5, a 0.5 mm lesser than the donor tissue, 400 microns was refined. Then the same dissection was continued on the host cornea. So here we are checking the depth of the trephination. With an MVR blade, the depth was little deepened, and with this crescent, similar kind of pocket is made from the refined area till the limbus, all around 360 degrees. So with the crescent it is made, and with the repositor it is checked all around, so that we are sure that we have made a pocket all around. Then with the right-left corneal scissors, the cornea is cut 360 degrees. Then viscoelast is put in the anterior chamber to form the anterior chamber. This is a photograph showing the full thickness conventional PK where the cut is vertical. This is a tuck-in keratoplasty where the cut is around, there is a peripheral flange, and you can see the greater surface area when compared to the normal conventional PK. Then what the donor tissue is put on the host cornea, and it is sutured like a routine keratoplasty. The suture is taken on the superior part of the graft, avoiding the flange, and we are making sure that the flange goes into the scleral corneal pocket whatever we have made. Then the suturing is like routine keratoplasty. First we put anchoring force sutures. The superiorly is put first. The inferior part is taken care that we have an equal division of the tension on the tissue. Then after putting 8 sutures, the Fleringa ring is removed, and rest of the 8 sutures are finished. Then at the end of the surgery, the sutures are buried, the anterior chamber is formed with saline, and the graft apposition is seen and confirmed there is no leak. This is a post-op 1-week photograph showing the clear cornea in the center, clear graft, and the ASOCT shows the peripheral tucking of the graft. And after 7 months, all the sutures of this patient was removed, and the best corrected visual acuity was 618. This is the second patient where we have done. So this technique was initially described by RP Center by Dr. Ashish Vajpayee in 2005. It was published in Cornea. So they have done in 8 cases of similar corneal decompensation, and at the end of 4 months they have removed all the sutures. And this is a similar procedure which is described in the picture of the journal. So 8 millimeters of the donor tissue is taken, and the peripheral flange is around 10 millimeters, and the peripheral flange is tucked into the corneal pocket and it is sutured. So the advantage is the greater surface area of apposition when compared to the conventional PK, which gives greater wound stability, wound strength, and the sutures can be removed early. So these are the photographs which were mentioned in the article. So showing a clear cornea at the end of around 6 months, and almost all the sutures were removed at the end of 6 months. So this technique is an alternative to conventional PK, where it gives an advantage of having a lamellar configuration in the presence of full thickness graft, and peripheral lamellar flange of the donor lenticule is anchorly secured in the groove created in the recipient bed, which allows for the better tectonic strength, and this gives early suture removal and lesser suture related complications like wound infiltrate. So, thank you so much.
Nice video.
Thank you.
Nice video, but I just have 2-3 comments. First of all, it's not a new technique.
Yeah, it is not a
You were
new
saying it's a new technique. I was wondering why you're calling it a new technique.
No,
because
it's not a new
almost 2
technique.
decades ago, Dr.
Yes,
Vajpayee has described it. Second thing is, actually this technique has no purpose. No offense, but in a lamellar keratoplasty, tuck-in makes sense. In a penetrating keratoplasty, you're still suturing at the from your 8 millimeter margin. You're not suturing at the posterior margin.
No.
So it's not like your sutures will induce lesser astigmatism, because
But,
the graft
yeah.
where you're suturing is the same size. Second thing is, you're not getting the benefit of those additional endothelial cells because you're tucking them under the pocket. So it's not like a top hat also.
Yes.
And third thing is, it cannot cause lesser astigmatism because your graft host junction becomes very bulky, and it is not cut by a femtosecond laser, you're cutting it manually. So the edges cannot be round. So in fact, you might end up with more astigmatism. So and it takes much longer to do, the surgical time is prolonged.
Surgical time is more than the normal.
So as the surgical time gets prolonged, more endothelial cells gets killed also. So although it's an additional technique, I don't think for a full thickness, tuck-in lamellar keratoplasty really has a role. I'm saying it because there's some audience sitting here and somebody might go back and try to do this. Obviously, it's not caught on in these 2 decades, and there's a reason for that. So for lamellar keratoplasty, it still makes sense, but for penetrating, I'm not so sure.
Thank you, sir. Thank you, sir.
Congratulations.
Vitreoretinal surgery involves complex and intricate maneuvers which can be unforgiving at times. We now present a compilation of these rare complications during vitreoretinal surgery and their management. This video demonstrates the subretinal migration of intraocular foreign body. After initial vitrectomy, a foreign body is noted close to the ora serrata with retinal break. The foreign body appeared to be stabbed in the choroid. After completing the vitrectomy, while examining the same area, the foreign body was not found. However, it had migrated subretinally under the macula. Subsequently, with the help of the magnet, the foreign body was steered through the peripheral retinal break and eventually through the sclerotomy. This video demonstrates the subretinal injection of brilliant blue dye during macular hole repair surgery. After completing the pars plana vitrectomy, fluid air exchange was done. Brilliant blue dye was injected, and here the subretinal dye was noted inferior nasally. After completing the ILM peeling, partial removal of the subretinal dye was performed using the flute needle. After air exchange, laser barrage was performed around the break. This video demonstrates the subretinal air migration during fluid air exchange in a case of an aphakic inferior bullous retinal detachment. After completing the vitrectomy, peripheral vitreous base excision was done. Fluid air exchange was started, and here subretinal air migration was noted. In an attempt to remove the subretinal air, further migration was noticed. A repeat fluid air exchange also led to the same complication. Subsequently, heavy perfluorocarbon liquid was injected, which then also migrated subretinally. In suspicion of peripheral traction as a cause of subretinal air migration, 360 degrees of relaxant retinectomy is performed. Subretinal bands were removed. Retina was attached under heavy liquid. 360 degrees endolaser was performed at the edge of the retinectomy, and silicone oil is exchanged for heavy liquid. Successful retinal attachment was hence achieved. This video demonstrates suprachoroidal migration of perfluorocarbon liquid through choroidal hole during retinal detachment repair surgery. A 6-year-old girl had undergone pars plana lensectomy and vitreous biopsy for traumatic endophthalmitis. Subsequently, she developed retinal detachment. During the retinal detachment repair, soon after removing the membranes, a large iatrogenic retinal break was noted. Then, a peripheral choroidal break was also noted. After completing the peripheral vitrectomy, perfluorocarbon liquid was injected. The retina appeared to be attached, but retinal bulge was noted temporarily. On careful examination, suprachoroidal migration of perfluorocarbon liquid through the choroidal break was noted. The presence of this perfluorocarbon liquid in the suprachoroidal space can be seen here. Suprachoroidal perfluorocarbon liquid was carefully removed. However, further migration was observed. A decision was taken to perform a retinectomy below the level of the choroidal break. Then, fluid air exchange was performed. The choroidal hole appeared to be flat with attached retina under air. Silicone oil was injected, and now suprachoroidal migration of silicone oil is noted, which was then removed through active suction. Nasal choroidal bulge was still noted at the end of the surgery. This video demonstrates subretinal hemorrhage during external drainage during Chandelier scleral buckle surgery. After conventional Chandelier scleral buckle surgery, a cut-down technique was used for external subretinal fluid drainage. We noticed sufficient subretinal fluid was drained. Fundus view showed subretinal hemorrhage at the posterior pole. The drainage site was sutured. Scleral buckle was secured in its position. 0.3 ml of pure C3F8 gas was injected, and patient was advised strict prone position. At 1 month follow-up, subretinal hemorrhage was noted to be displaced. This video thus shows various rare complications that occur during vitreoretinal surgery and novel ways of managing them successfully.
Thank you. So most of this, I want to highlight my videos. Most of this is performed by the fellow trainees, and they are all very vicious competition. under guidance of the consultants. So they're just highlighting how these complications occurred, how to prevent them, and how to successfully manage them. Thank you. It's it's the playing didn't get converted properly. Yeah. Thank you.
Congenital hereditary endothelial dystrophy is characterized by bilateral diffuse corneal thickening associated with a varying degree of stromal opacification due to endothelial dysfunction. The severity of the stromal scarring, extent of degenerative pannus formation, secondary changes like band-shaped keratopathy, presence of nystagmus, sensory deviations due to late presentation, and associated comorbidities like glaucoma are poor prognostic factors. Conventionally, CHED has been managed with reasonable success by performing penetrating keratoplasty. The published literature and our own experience has shown very good long-term anatomical success after penetrating keratoplasty. Considering the longevity of children with CHED, often fraught with suture-related complications, infections, graft rejection, failure, cataract, glaucoma, and reintervention, PK has had less impressive long-term functional success. In our experience, DSEC has shown promising long-term results even in children with CHED with better graft host and refractive stability. Nevertheless, there may be lack of pristine corneal clarity after DSEC as compared to PK. DSEC in these situations presents its own challenges. The procedure is technically demanding due to a crowded anterior chamber, low corneoscleral rigidity, poor visibility, risk of inadvertent injury to lens and iris while performing desmetorexis. In addition, the thick desmase endothelial complex further compounds the DM stripping, and the inadvertent pull of the stromal fibers results in poor interface, thus directly influencing the final stromal clarity. All these difficulties necessitated modification in the surgical steps. We have successfully shown that desmase stripping is an avoidable step while performing endothelial keratoplasty, provided desmase endothelial complex is optically clear, free from guttae, pigments and scars. The lesser surgical time, minimal instrumentation, a smoother surgical interface and early stromal clearing together favored this technique over conventional DSEC. Our long-term results and objective assessment using corneal densitometry revealed superior outcomes. In a subset of our patients with severe ground glass corneal opacification due to late presentation, DSEC was attempted in conjunction with superficial keratectomy and mitomycin C application, which resulted in significant resolution of corneal haze. The donor graft dissection was done using Moria microkeratome. A 4 to 5 mm clear corneal incision was made. Single stab wound was performed according to the surgeon's convenience and sterile air was injected. Air in the anterior chamber would help in discerning any abnormalities of the desmase endothelial complex and posterior stromal fibers. Presence of any guttae or pigments will be seen. This step helped in deciding whether desmase membrane could be spared. The corneal surface was marked with an appropriate size trephine for lenticule centration and sizing. The posterior lamellar graft was inserted using a sheath glide, protecting the endothelium with sodium hyaluronate 1%. Following graft insertion, full chamber airfill was maintained for 10 minutes. After sealing all the ports, the anterior chamber was filled with full chamber air bubble. These robust steps would ensure that mitomycin C would not seep into the anterior chamber. At the end of 60 seconds, the corneal surface was thoroughly washed off with saline and bandage contact lens was applied when required. Serial examinations were performed at day 1 and at 1 week after surgery to assess the intraocular pressure, graft adherence, and epithelial healing. Subsequent follow-up examinations were scheduled at 1, 3, 6, and 12 months after surgery. Postoperative anterior segment OCT and densitometry measurements allowed us to qualitatively measure the graft host dynamics and corneal clarity, maximizing the visual success during the rehabilitative journey. To conclude, children with visually significant stromal opacification in cases of CHED can achieve excellent visual outcomes and realize a significant improvement in corneal transparency by undergoing simple, non-desmate stripping endothelial keratoplasty in conjunction with superficial keratectomy and use of mitomycin C.
Thank you for your kind attention. If there are any questions, I will answer.
Thank you, Dr. Muralidhar, for a
Thank you.
wonderful video. So, what is the mechanism? I mean, how would mitomycin work here to get the
Yeah.
cornea clear?
So as you know, this particular entity is an endothelial abnormality. So they end up having a dense degenerative pannus on the corneal surface. So once we resect, once we perform a superficial keratectomy, even including your Bowman's membrane is damaged completely, it leaves behind a haze. It's something like analogous to PRK. When you do a PRK, and we normally apply a mitomycin in order to reduce the haze, which mitomycin, it only prevents the ongoing, the scarring or a haze mechanism. If already has a pre-existing scar or a haze, it doesn't have any influence. So since I have performed a very delicate superficial keratectomy, just want to remodel the tissue, thereby, you have a much better transparency. And as we know, the cornea, the air tear film interface, that's the most important. So I don't want any haze in the anterior surface, thereby you have a less aberrations, and the child, particularly during neuroplasticity, have a error-free vision, thereby we can maximize their visual potential.
I think this is very important, particularly in kids. If we start them early on amblyopia therapy, so it would have a huge impact as far as their amblyopia is concerned. Thank
So
you.
there has been a sea change the way we manage. Earlier, conventionally we used to do penetrating keratoplasty. Considering the longevity, so the 10-year survival rate used to be around 60%. Having switched to DSEC and NDSEC, we have a little over 98% is our success rate. That's a 10-year survival rate. So this is a long way it goes in these cases, right?
Does it reduce the number of drops in follow-ups?
Yes,
steroid drops?
yes. Even the rejection has been found to be 10-folds much lesser, okay? And even if you have a rejection, is much more reversible. So beyond 18 months, we can actually switch off steroids or put them on a soft steroid. Thereby, you can minimize the potential risk of long-term steroid usage, like steroid-induced glaucoma, cataract, and so on forth.
Thank you. I
Thank
think
you,
this
sir.
was a wonderful video. So, is there any question in audience for Dr. Muralidhar? So we will move to the next video. Dr. Padmaja Kumari Rani, she will be presenting the video titled as the buckling the macula.
Good morning, everyone.
Please run the video.
In the right eye. His best corrected visual acuity was counting fingers in the right eye and 20/80 in the left eye. The right eye axial length was 30.81 millimeters. His anterior segment examination was normal in both eyes. Posterior segment examination showed a macular hole with associated posterior pole retinal detachment and posterior staphyloma in the right eye. Also, the OCT images confirm the presence of full thickness macular hole with retinal detachment. The macular buckle surgical procedure was planned for episcleral macular indentation. A 360-degree conjunctival peritomy was done with radial oblique relaxing incisions while avoiding the horizontal incisions to prevent the buccal exposure. The subtenuous dissection was adequately done in all four quadrants. The four recti muscles were tagged with a 2-0 silk suture. The muscle was adequately exposed, beginning with tenuous dissection at the lateral walls of the muscle. The superior oblique and the inferior oblique muscles were retracted with the right muscle hook to facilitate smooth passage of the silicone band. Cohesive viscoelastic was used for the smooth passage of the band through the wedge. The modern day vein T-shaped macular buckle is prepared with a 4 mm wide silicone band through passing through a 7 mm wide silicone macular wedge that appears convex on one side. The silicone band was negotiated under the 4 recti, 2 oblique muscles and the inferior vortex veins. The macular wedge was gently positioned under the lateral rectus muscle with its convex side towards the macula and maneuvered till it reaches under the posterior staphyloma. A chandelier illumination was used to accurately localize the macular wedge indentation beneath the macular hole in the posterior staphyloma. Care should be taken to avoid damage to the vertex veins perforating the globe, injuring the optic nerve. Appropriate location of the macular buckle was marked with a sterile ink marker. The macular buckle and the band were together secured to the sclera with a 5-0 Dacron suture. The conjunctiva was meticulously closed with a 7-0 Vicryl suture. The patient was put on topical steroids and cycloplegics and antibiotics and was given oral pain relieving medications for 1 week. At the 5-week follow-up, the vision had improved in the right eye from counting fingers to 2160 with successful closure of the macular hole and resolution of retinal detachment. The OCT and B-scan ultrasonography images show a proper indent with the retinal detachment completely resolved. Macular buckle surgery counters the pulling effect of the posterior staphyloma and restores the functional vision in highly myopic patients, provides good anatomical and functional outcome, and solves the mystery behind the treatment of such detachments.
Thank you. No, it is previously the macular buckle surgery means we used to disinsert the muscles, and it was very difficult technique because these are eyeballs with very high axial length, 30.81 and everything with sclera. But with this T-shaped implant, you can actually pass it underneath, and chandelier assisted illumination will help us to see indent accurately. Otherwise it can be a blind technique. So that way these eyes, we need to be careful, and the surgery should be done under general anesthesia because you want the exposure, and during the procedure you need to be very gentle and mediculate. So these surgeries will take 2.5 hours, but for video purpose we edit to 8.5 to 8 minutes. But it is definitely, these are frustrating retinal detachment, and if the macular buckle is the only solution, when it works like magic.
Okay. Did you look at the axial length when you put at the posterior pole? The staphyloma would reduce it.
Yeah. In fact,
so what was the post-operative?
Post-operative, it was actually reduced to 4 mm. Means in the sense 30 mm was the axial length, so it was around 26 mm. And and the appropriate indent will definitely help us to achieve the satisfactory anatomical and functional outcomes.
Yes.
Dr. Padpanja, something similar to this was done by Professor Momose long back in 1986, which was called as a posterior scleral support operation. It was basically aimed at reducing the axial length so that there is a halt in the progression of myopia. Over a period, I don't think it was very successful, but this is something very similar to that. And then another thing which I wanted to ask you is, how long do you retain
the buckle will be permanent. Yes.
Permanent.
In fact, in these eyes, when we do vitreoretinal surgery and when we leave oil, as soon as you remove oil, or again the retinal detachment will be the same, because you just can't get any perfect anatomical attachment because of the posterior cephaloma. Whereas the buccal indenting, if buccal works, that is the only solution which can work magically here.
Maybe one suggestion would be if you're doing it in younger individuals,
Yeah.
whether it's also trying to halt the progression of myopia.
Yeah.
So I just wanted to, talk about the same thing, because we see as a pediatric ophthalmologist very often this patient as a myopic strabismus fixus.
Correct.
And they do have, the elongated posterior pole. So if this works, then
Yes.
probably we can, stop the progression as well as, the outcome as far as the strabismus fixus. When we try to do a loop myopexy, probably that will have a
Yes.
impact as far as the alignment is concerned. And another thing, recently, Dr. Dimmer has published or shown similar cases with, the blobby eye syndrome. I mean, they don't have the staphyloma at the posterior pole, but at the equator.
Okay.
So probably in those cases, even for as a retina surgery also, it would be easy to reach at the equatorial.
Yes.
Equatorial staphylomas and back up them there. And then probably we have a good
I think
strabismus outcome.
it's an interesting future directions, and it is available
Probably
for
we have to
5,000 rupees.
work on that.
It's not very costly, expensive thing, and Chandelier really helps us to see the indent, and it gives you a lot of confidence that you are reaching in the right direction. Thank you.
So, thank you, Dr. Padmaja Kumari. It was wonderful. We all enjoyed it.
Caution that the PC should not move anteriorly. Foldable lens is implanted into the posterior chamber, into the bag. The viscoelastic is washed out. The wounds are hydrated, and then only after that the irrigation cannula is removed. So that's the end of the surgery, and conventional approach would be that hydrodelineation is advocated, and then the rest of the cortex is aspirated out. But here I use a hydrodissection technique in posterior polar cataract. So that's what I wanted to highlight. And it's basically a relatively simpler technique as compared to the hydrodelineation plus the remaining maneuvers. No, actually I couldn't manage that.
Does audience has any question for? Please move on to next video.
Yes, right. This was a lady who presented with phacomorphic glaucoma 3 days after the onset of the attack, and the lens was almost touching the cornea. So she had very significant edema, and the pupil was not dilating. We did a temporal clear corneal phaco, and prior to the surgery, we reduced the IOP with hyperosmotics. So what I'm trying to do is initially just create some space and stretch the pupil. So I'm injecting viscode here, which is a cohesive, dispersive viscoelastic, and I'm using Kuglin hooks to stretch the pupil. Once the pupil is dilated, I wash off the viscoelastic to allow staining of the anterior capsule. Trepan glue is used to stain the capsule, which is washed out, and again the capsulotomy is initiated with the cystitome.
you can see how the cornea is hazy, and visualizing the capsule is very difficult. It is continued with a rhexis forceps. So somehow I managed to get a capsule rhexis there, but it was quite big in size. I made another port with partial entry into the anterior chamber so that the chamber remains stable. The cornea started becoming hazy during the surgery as we injected viscoelastic. So now towards the end again it's clearing a little bit. Because of the big rhexis, the nucleus came into the anterior chamber. I'm trying to do the surgery as far away from the cornea as possible. Whatever peripheral cortex was there was washed out, but the central cornea is still hazy. At the end, I put a little triamcinolone because there was a lot of inflammation prior to the surgery also. And I didn't implant an IOL because I couldn't get a IOL power because of the corneal edema. So I planned to put a secondary IOL later on, but the patient didn't turn up later. Right. 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 Those things were basically there when the surgery was either ECC or SICS sort of thing. But phaco, because we have this well-maintained chamber, there's less likelihood of that kind of complication happening. Yes. Please go on to the next video. This is a slightly longer video. It's basically a cataract in a patient with Fuchs uveitis, a 19-year-old boy, and he presented with an intumescent cataract. So the important thing is that I want to highlight here is surgery in Fuchs iridocyclitis is very different from other uveitis, and it is relatively simpler. But it is likely to present with this intumescent sort of appearance, and the same precautions that are taken while doing an intumescent cataract surgery have to be taken here. So I prepared the patient pre-op with glycerol, 1 gram per kg of body weight, and again I am doing a temporal clear corneal surgery. .8 millimeter incision is made. Staining the anterior capsule for better visualization with trypan blue. initially the air bubble is removed with HPMC. And then I inject viscose over that to maintain the chamber. Rhexis is initiated with acetylene. The moment the capsule is punctured, very minimal. If excess of visco is injected, it might further stretch the capsule and lead to a tear. The capsulorhexis forceps is used to complete the rest of the capsulorhexis. It's important to re-grasp the flap as close to the leading edge of the rhexis as possible. And particularly because the patients in Fuchs are young and they present at an early age, so the capsule is also elastic, making it more likely to run to the periphery. Now, as I start the phaco, it hardly takes 10 seconds for the whole of the cataract to be removed. This is a real-time video. So, except a few cortical fibers, the whole lens has been, the whole cataract has been cleared. And the rest of the video is a routine lens implantation. So, I think we can stop the video here. No, that's not mine. Yes.
Yes. Yes, so what was, being a child and, the intumescent nature of the cataract, did you notice there are some clefts within the nucleus and the substance of the lens?
No, it was not a child, he was a teenager, sort of 19, 20 kind of guy.
Yes. It's a pediatric sort of thing.
Yes.
So because, usually the real difficulty comes in intumescent where, those clefts are already formed. So that indicates, the actual high intralenticular pressure. I think you are quite lucky. This is not too high intralenticular pressure. Otherwise, it is very difficult to actually do a circular ACC
No, but
without
what
decompressing the entire capsule. So you need to first immediately decompress the capsule by giving a nick and then aspiration of the lens matter a little bit, so that rest of the the steps you can perform. So I think I would say it was not a pure intumescent with a very high intralentricular pressure.
No, it was not the super intumescent kind of thing, but what I showed you, the previous phacomorphic one, or something like that only. I keep doing this glaucoma surgeries. The technique that I use, I mean, I stick to that only. Since last 2-3 years I have been doing that. Giving glycerol prior to surgery, and then using Viscode intraoperatively, and then completing the access with the forceps.
Okay, thank you.
Thank you. Thank
So
you.
we'll move to the next video. So we have Dr. Sai. Mr. Syed Musa. I think he is not there. Okay. So Dr. Vanita Pathak Ray. Could you please find out? Please run video number 4. Yeah.
Hereditary endothelial dystrophy is characterized by bilateral diffuse corneal thickening associated with a varying degree of stromal opacification due to endothelial dysfunction. The severity of the stromal scarring, extent of degenerative pannus formation, secondary changes like band-shaped keratopathy, presence of nystagmus, sensory deviations due to late presentation, and associated comorbidities like glaucoma are poor prognostic factors. Conventionally, CHED has been managed with reasonable success by performing penetrating keratoplasty. The published literature and our own experience has shown very good long-term anatomical success after penetrating keratoplasty. Considering the longevity of children with CHED, often fraught with suture-related complications, infections, graft rejection, failure, cataract, glaucoma, and re-intervention, PK has had less impressive long-term functional success. In our experience, DSEC has shown promising long-term results even in children with CHED with better graft host and refractive stability. Nevertheless, there may be lack of pristine corneal clarity after DSEC as compared to PK. DSEC in these situations presents its own challenges. The procedure is technically demanding due to a crowded anterior chamber, low corneoscleral rigidity, poor visibility, risk of inadvertent injury to lens and iris while performing desmetorexis. In addition, the thick desmase endothelial complex further compounds the DM stripping, and the inadvertent pull of the stromal fibers results in poor interface, thus directly influencing the final stromal clarity. All these difficulties necessitated modification in the surgical steps. We have successfully shown that desmase stripping is an avoidable step while performing endothelial keratoplasty, provided desmase endothelial complex is optically clear, free from guttae, pigments, and scars. The lesser surgical time, minimal instrumentation, a smoother surgical interface, and early stromal clearing together favored this technique over conventional DSEC. Our long-term results and objective assessment using corneal densitometry revealed superior outcomes. In a subset of our patients with severe ground glass corneal opacification due to late presentation, DSEC was attempted in conjunction with superficial keratectomy and mitomycin C application, which resulted in significant resolution of corneal haze. The donor graft dissection was done using Moria microkeratome. A 4 to 5 millimeter clear corneal incision was made. Single stab wound was performed according to the surgeon's convenience and sterile air was injected. Air in the anterior chamber would help in discerning any abnormalities of the Descemet's endothelial complex and posterior stromal fibers. Presence of any guttate or pigments will be seen. This step helped in deciding whether Descemet's membrane could be spared. The corneal surface was marked with an appropriate size trephine for lenticule centration and sizing. The posterior lamellar graft was inserted using a sheath glide, protecting the endothelium with sodium hyaluronate 1%. Following graft insertion, full chamber airfill was maintained for 10 minutes. After sealing all the ports, the anterior chamber was filled with full chamber air bubble. These robust steps would ensure that mitomycin C would not seep into the anterior chamber. At the end of 60 seconds, the corneal surface was thoroughly washed off with saline and bandage contact lens was applied when required. Serial examinations were performed at day 1 and at 1 week after surgery to assess the intraocular pressure, graft adherence, and epithelial healing. Subsequent follow-up examinations were scheduled at 1, 3, 6, and 12 months after surgery. Postoperative anterior segment OCT and densitometry measurements allowed us to qualitatively measure the graft host dynamics and corneal clarity, maximizing the visual success during the rehabilitative journey. To conclude, children with visually significant stromal opacification in cases of CHED can achieve excellent visual outcomes and realize a significant improvement in corneal transparency by undergoing simple, non-Descemet stripping endothelial keratoplasty in conjunction with superficial keratectomy and use of mitomycin C.
Degenerative myopia, pathological myopia, or malignant progressive myopia is an irreversible elongation of the eyeball, which damages the retina and associated structures of the eye and determines the patient's best corrected visual acuity. Highly myopic eyes generally have developmental scleral ectasia, which is a distension of the posterior pole of the eye known as posterior staphyloma and is associated with vitreoretinal traction. The image here shows the fundus of a highly myopic eye with a macular hole labeled by a yellow circle and the associated retinal detachment marked by a red circle. The OCT image shows a full thickness macular hole with posterior pole retinal detachment. The pathophysiology in the anterior tract is caused by the vitreoretinal interface, a presence of posterior staphyloma, and weak adhesions between the neurosensory retina and retinal pigment epithelium. Macular buccal surgery is emerging as a promising modality in the management of a macular hole with associated retinal detachment in patients with myopic traction maculopathy. The macular buccal is a medical grade silicone implant, a product of France Chirurgie Instrumentation. It is available as a sterile biocompatible product and indented for a single use. Macula buccal enables episcleral macular indentation of the posterior staphyloma, relieving the vitreoretinal traction and opposing retinal pigment epithelium to the neurosensory retina. Our patient was a 51-year-old gentleman with decreased vision of 6 months duration in the right eye. His best corrected visual acuity was counting fingers in the right eye and 20/80 in the left eye. The right eye axial length was 30.81 millimeters. His anterior segment examination was normal in both eyes. Posterior segment examination showed a macular hole with associated posterior pole retinal detachment and posterior staphyloma in the right eye. Also, the OCT images confirmed the presence of full thickness macular hole with retinal detachment. The macula buccal surgical procedure was planned for episcleral macular indentation. A 360-degree conjunctival peritomy was done with radial oblique relaxing incisions while avoiding the horizontal incisions to prevent the buccal exposure. The subtenon dissection was adequately done in all 4 quadrants. The 4 recti muscles were tagged with a 2-0 silk suture. The muscle was adequately exposed, beginning with tenon dissection at the lateral walls of the muscle. The superior oblique and the inferior oblique muscles were retracted with the right muscle hook to facilitate smooth passage of the silicone band. Cohesive viscoelastic was used for the smooth passage of the band through the wedge. The modern day vein T-shaped macula buccal is prepared with a 4 mm wide silicone band through passing through a 7 mm wide silicone macular wedge that appears convex on one side. The silicone band was negotiated under the 4 recti, 2 oblique muscles and the inferior vortex veins. The macular wedge was gently positioned under the lateral rectus muscle with its convex side towards the macula and maneuvered till it reaches under the posterior staphyloma. A chandelier illumination was used to accurately localize the macular wedge indentation beneath the macular hole in the posterior staphyloma. Care should be taken to avoid damage to the vertex veins, perforating the globe, injuring the optic nerve. Appropriate location of the macula buccal was marked with a sterile ink marker. The macula buccal and the band were together secured to the sclera with a 5-0 Dacron suture. The conjunctiva was meticulously closed with a 7-0 Vicryl suture. The patient was put on topical steroids and cycloplegics and antibiotics and was given oral pain relieving medications for 1 week. At the 5-week follow-up, the vision had improved in the right eye from counting fingers to 21/60 with successful closure of the macular hole and resolution of retinal detachment. The OCT and B-scan ultrasonography images show a proper indent with the retinal detachment completely resolved. Macula buccal surgery counters the pulling effect of the posterior staphyloma and restores the functional vision in highly myopic patients, provides good anatomical and functional outcome, and solves the mystery behind the treatment of such detachments.
There are several causes of hypotony in the early postoperative period. Wound leak and overfiltration being the commonest. Our 29-year-old patient underwent routine topical trabeculectomy with injected mitomycin C for uncontrolled intraocular pressure on maximal treatment in advanced juvenile open-angle glaucoma. In the early postoperative period, his bleb was large with an extremely shallow anterior chamber and an IOP in the range of 4 to 6 mm mercury and was presumed to have overfiltration. He was being managed conservatively in the absence of choroidal elevation. However, within a month, he developed hypotony maculopathy and decrease in vision to 20/100. At this point, ciliary body cleft was also considered as a possibility, but was ruled out with an ultrasound biomicroscopy. He was most reluctant for revision surgery but consented to compression sutures. This too was done under topical anesthesia. However, this failed to resolve the hypotony maculopathy, and he had to be convinced of the merits of a revision procedure. In the operating room, under sterile conditions and with the aid of a corneal traction suture, conjunctiva was incised superiorly at the limbus. To our surprise and dismay, no scleral flap was seen. Instead, 4 full thickness fistulae were visible in the exposed scleral bed. These were promptly sutured with 10-0 nylon interrupted sutures. In the absence of availability of a scleral patch graft, autologous partial thickness sclera was harvested from the opposite limbus. This was then placed over the scleral bed and sutured with 2 interrupted 10-0 nylon sutures at the limbus. A mattress suture was also placed across the breadth of the scleral patch graft at the limbus. Posteriorly, 2 interrupted sutures were placed at the 2 corners of the graft. The ragged conjunctival edge was cut and regularized. Edge was closed with 8-0 Vicryl sutures, interrupted and mattress. Donor site was also sutured with 8-0 Vicryl suture. Postoperatively, anterior chamber was deep and there was a slow recovery to normal vision with resolution of hypotony maculopathy. The donor site also healed without sequelae. More than 2 years of follow-up is now available and patient has deep anterior chamber with normal IOP without medication. More importantly, his vision recovered to normal. He has since undergone routine topical trabeculectomy with injected mitomycin C in the fellow eye about 6 months ago without any postoperative complications. Mitomycin C is known to cause several side effects, including wound leak in the early postoperative period, ischemia of bleb with thinning and leakage, often with full thickness fistula, is usually seen in the late postoperative period. However, such a presentation in the early postoperative period for our patient with melting of scleral flap and presence of multiple fistulae is rather unusual. We surmise that inadvertent concentrated dose of mitomycin C could have been injected, as the authors have now performed over 200 such standard procedures, injecting a fixed dose of 20 micrograms prior to filtering surgery, with or without phaco, with no unwanted sequelae. In this case, some smart thinking helped us to mitigate the adverse condition. Therefore, autologous partial thickness sclera is a viable alternative to full thickness donor sclera for repair of fistulae post trabeculectomy with mitomycin C.
lovely video.
Thank you.
I just want to know how the IOP came back to normal after you closed like the whole area with a patch.
It became a guarded filtration once again.
Okay.
And the...
So you still have a little bleb.
Oh, the last bleb was his. Yes, he's beautifully controlled at 10 millimeter mercury. His vision has recovered. His hypotony maculopathy has completely disappeared.
Very nicely managed.
We'll go to the next video. Please run the next video.
Technique of topical, modified, fornix-based, twin-site phacotrabeculectomy with injected mitomycin C. Phacotrabeculectomy is increasingly deployed in the management of cataract and glaucoma, as both tend to be diseases of advancing age. Phacotrab has traditionally been performed under regional anesthesia as the procedure tends to be relatively long. However, peribulbar anesthetic injections are not without pitfalls. We present a technique that not only avoids peribulbar anesthesia but also helps to minimize time on the table, and we start by injecting a small amount of mitomycin C in the preoperative area. Preparation of the eye in this area is with topical anesthesia and betadine eye drops 3 times at least 10 minutes apart. Mitomycin C is freshly reconstituted on the day to a concentration of 0.4 milligram per mil or 0.04%. 0.05 mils of this is then drawn in a 1 ml syringe together with 0.05 ml of 2% lignocaine for a final concentration of 0.02% mitomycin C. This is then injected 8 to 10 millimeters away from the limbus superiorly, and a bleb is raised. Cotton buds are then used to diffuse the mitomycin C over the superior bulbar conjunctiva. Patient is shifted to the OR 20 to 30 minutes later, and under sterile conditions, separate site phaco and trabeculectomy are done superiorly with the use of intracameral unpreserved lignocaine. Traditionally, in separate site combined surgery, a conjunctival incision is made superiorly and a clear corneal phaco wound is made temporally. In a modification of this technique, which avoids change of position for the surgeon, both the incisions are accommodated superiorly. Depending on the side being operated, for the right eye, the conjunctival incision for filtration is made supranasally and the phaco wound supratemporally, both side by side and therefore twinned. This is reversed for the left eye. The conjunctival incision is made supratemporally and the phaco wound supranasally. Conjunctiva is incised 1 to 1.5 millimeter from the limbus. If required, unpreserved 2% lignocaine may be infused under the conjunctiva. A 1/3 to half thickness, partial thickness scleral flap is lifted using a tunneling knife and the sides are released minimally. Paracentesis with slow decompression of the globe is done and 0.5 mils of unpreserved lignocaine, 2% is injected. Continuous curvilinear capsulorhexis is completed after viscoelastic injection. Following this, 2.8 millimeter clear corneal phacoemulsification wound is made by the side of the filtration wound, and phacoemulsification is performed by the preferred technique. Here, direct chop was employed. A posterior chamber intraocular lens is inserted and the wound is closed with 10-0 nylon suture. Returning to the trap site, anterior chamber is entered with an MVR blade under the scleral flap, and a sclerostomy is constructed with Kelly's sponge, followed by an iridectomy. 10-0 nylon is then used for the sclera, and 10-0 Vicryl running mattress for the conjunctiva. The wound and side ports are hydrated, and lifting of bleb with watertight closure of conjunctiva is checked. Relative advantages of the procedure are: topical anesthesia avoids pressure on the optic nerve from the volume of peribulbar injection, so it is safe in advanced glaucoma. Injected mitomycin C helps to deliver fixed dose of the drug in a repeatable fashion. It helps to produce a diffuse, low, posteriorly directed bleb, avoiding anterior, thin-walled, cystic, high blebs which are prone to late leaks and blebitis, as well as bleb-associated endophthalmitis. Also, such blebs are symptomatic and can cause Dellen and dysesthesia. In twin-site surgery, separation of phaco and filter helps to minimize tissue handling and subsequent decreased inflammation and fibrosis. Filtration wound 1.5 mm away from the limbus, and our type of conjunctival closure avoids astigmatism. It also spares limbal stem cells, preventing conjunctivalization of the cornea and overhanging dysesthetic blebs. The age-old criticism of a separate site surgery has been that it can be time-consuming. This is well addressed by our technique, where time spent around sponge application of mitomycin C is saved. Also, no time is lost in change of surgeon position by twinning the two sides rather than separating them as superior and temporal. Topical phacotrabeculectomy is very much a reality when injected mitomycin C is used in separate site surgery, which is twinned.
I think the video is very self-explanatory. I don't have any comment or question. Does the audience has any comment or any question for Dr. Venuka? Yeah, if not, then we'll move to the third video.
Aqueous misdirection is a dreaded complication, but fortunately very rare. It usually occurs after intervention for angle closure glaucoma. Our patient also had primary angle closure glaucoma, for which she had phacotrabeculectomy in the left eye elsewhere. Following her surgery, she developed aqueous misdirection, for which she then received a pars plana vitrectomy and hematglaucoma valve, also elsewhere. She presented 6 weeks after pars plana vitrectomy with a flat anterior chamber, corneal edema with folds in decimase, pigmentary membrane over the pupil, tube barely visible in AC, and 2 patent PIs with an IOP of 26 mm mercury on 3 anti-glaucoma medication. There was no view of the fundus, and choroidal detachment was excluded with a B scan. Fellow left eye was shallow with a patent PI and cataract. Disc was normal. Diagnosis of recurrent aqueous misdirection was made in the left eye, and she had a YAG hyaloidotomy, following which the AC deepened marginally. She was then scheduled for a zonulo-hyaloidovitrectomy through her pre-existing PI soon thereafter, as corneal decompensation was a distinct likelihood. We present this relatively simple technique performed with an anterior vitrector using anterior vitrectomy settings by an anterior segment surgeon for prompt reversal of aqueous misdirection and a sustained long-term resolution. Preoperatively, patient received mannitol in appropriate dose for vitreous detergescence. In the operating room, under sterile conditions, a paracentesis was first made at 9 o'clock. Entry into the anterior chamber was difficult and was aided with viscoelastic. Iris repositor was then used for syneculisis. A corneal incision was made overlying the pre-existing peripheral iridotomy at 10 o'clock. And a 20-gauge vitrector was used to cut the pigmented pupillary membrane. A second paracentesis was then made at 3 o'clock position, and the vitrector was introduced almost vertically, initially facing the surgeon to enlarge the iridectomy and perform a zonulectomy. Following this, the vitrector is slowly rotated to face anteriorly whilst performing a hyaloidectomy. AC soon started becoming deep and stable. It became apparent that the tube was very superficial, and this was resighted to avoid corneal decompensation. Filtered air was then injected and AC was well formed. Post-operatively, the patient had a deep anterior chamber till last follow-up of 18 months. Recovery of vision to 2030 with clear cornea, tube being well positioned in the AC, and a controlled intraocular pressure without any medication. Disc was found to have an inferior notch with the cup disc ratio of 0.8 and corresponding superior arcuate field defect, just involving fixation on 10-2. Recurrence of aqueous misdirection is not unknown after pars plana vitrectomy and has been reported by several authors. It is perhaps a reflection of incomplete hyaloidectomy. We have a series of 9 eyes successfully treated with IZHV. We strongly recommend a complete anterior debulking of hyaloid and disruption of the hyaloid face, made possible by use of an anterior vitrector using anterior vitrectomy settings by an anterior segment surgeon, thereby reducing burden on the resources and skills required in a vitreoretinal procedure.
That is a very nice video. Has this been reported before? The use of vitrector through a PI for malignant glaucoma?
Well, it is not unreported, but after recurrent aqueous misdirection, no.
Okay. Very nicely done. And I think a lot of anterior segment surgeons who often encounter this problem can do in themselves and do this.
Yeah, it's not difficult at
They don't
all.
have to
And
send the
you
patient to a retina specialist if they don't have it in their practice.
yeah.
I think Dr. Padmaja has a comment.
Excellent videos, and yes, this vitrector we can use even now with the advent of 25 gauge vitrector. So we have reported in case of phakic eyes, 25 gauge vitrector, we can make an inferior iridozonulovitrectomy, and we have around 5 cases with 2 years follow-up with no cataract. By doing this zonulectomy, with the focal zonulectomy, we are not really causing any progression of the cataract, nor there is any zonular dialysis. And these eyes, once the AC deepens, that is the most important thing that we require at that moment. And all eyes are doing well.
So can I just make a point here? You are a posterior segment surgeon, I'm an anterior segment surgeon. What I'm trying to say is that we as anterior segment surgeons can easily manage this condition without actually depending on posterior segment surgeons and the cost in it involves.
Yes. No, I'm also telling the same thing. This technique we have published and the video can be followed, and even in anterior segment surgeons, they can use the 25 gauge vitrector even in phakic eyes.
Recent evidence from the EAGLE study suggests that lens extraction alone may be sufficient for control of angle closure disease. However, angle closure exists in various forms, and phacoemulsification alone does not seem to resolve the pure plateau mechanism of angle closure due to high ciliary body insertion. Plateau iris is apparent clinically as a relatively deep central anterior chamber, planar iris, and a double hump appearance on gonioscopy, despite the presence of a patent laser peripheral iridotomy. Anatomically, plateau iris is defined as anteriorly positioned ciliary processes that push the peripheral iris forward, resulting in iridotrabecular proximity. Ultrasound biomicroscopic studies performed before and after lensectomy demonstrate that iridociliary apposition seems to persist in plateau iris syndrome despite cataract extraction. Of late, endocycloplasty combined with phacoemulsification has been used to change the angle configuration. In endocycloplasty, diode laser energy is delivered endoscopically to the posterior aspect of the ciliary processes with the goal of shrinkage but not destruction. The surgical technique involves phacoemulsification and IOL surgery performed prior to endocycloplasty. We prefer a clear corneal incision for ease of access and its self-sealing properties. The same incision is typically used for both phacoemulsification and endocycloplasty. After phaco is completed and the IOL is in the bag, we fill up the anterior chamber with a cohesive viscosurgical device and introduce the endoscope in the AC to visualize the angle. Here, in this case, you can see the inferior 180 degrees. Except for 1 clock hour, the rest of the angle appears closed. We then mount the intraoperative AS-OCT onto the microscope and take images. Following this, we inject cohesive ophthalmic viscosurgical device to expand the ciliary sulcus and create space for the endoscopic probe. The 20-gauge curved ECP probe, which consists of a fiber optic camera and a diode laser, is placed through the main incision. We set the laser to continuous delivery mode with 250 to 500 milliwatts of power. We visualize the ciliary processes by passing the curved probe behind the iris and into the sulcus. A red aiming beam is aligned with the posterior aspect of the ciliary processes. It is important to start lasering at the posterior tail aspect of the ciliary processes and to observe the processes retreat posteriorly. The end point of laser treatment is marked by adequate shrinkage and whitening of the ciliary process. Care must be taken to avoid the application of too much energy, causing ciliary process to pop. Overtreatment may lead to excessive postoperative inflammation and a breakdown of the blood-aqueous barrier and its sequelae. It is possible to ablate approximately 30 to 40 processes through the phaco-incision. Once laser is completed, intraoperative ASOCT is repeated as seen here. Following this, the endoscope is reintroduced into the AC to visualize the angle yet again. Post-endocycloplasty, the scleral spur is now visible throughout the inferior 180 degrees. This is in stark contrast to the view after phaco and immediately prior to endocycloplasty. ASOCT has been done in several cases. All of them show increase in angle recess. Cycloablation pulls the entire ciliary process, including its anterior head, posteriorly. It thereby widens the anatomic angle and flattens the peripheral iris, along with photocoagulative effect of decrease in aqueous production. We conducted a pilot study of 10 eyes of 9 patients who were treated with combined phacoemulsification and endocycloplasty for angle closure disease. We have a median follow-up of 18 months now, and at this follow-up, median IOP decreased from 20 to 15.5 mm mercury, and the median number of anti-glaucoma medications decreased from 3 to 0. And logMAR visual acuity improved from 0.55 to 0. Currently, no treatment definitively addresses angle closure glaucoma secondary to plateau iris syndrome. Our preliminary results suggest that endocycloplasty in combination with phacoemulsification and an IOL implantation directly impacts on this underlying morphological anomaly. Anterior segment OCT provides direct evidence of this.
Because you can't really be sure it's going to be a plateau iris.
No, you can be sure prior to surgery. But yes, it is actually a procedure that can be utilized with cataract surgery in all cases. It spares the conjunctiva, so if you need a trab
Even
later
open
on,
angles you would try this?
Yeah, open angle, it is
Anyway,
established.
Yes.
It is established. It's angle closure. This is the first time that this has been done, and I've actually reported the publication is pending. I now have 30 eyes, median 15 months follow-up, and very favorable results. Well, over 30 eyes, 32 eyes. Yes, 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 yes.
Can we go on to the next video, please? This is the last video.
Approaching the trabecular meshwork from the outside, or ab externo, has been a surgical strategy used commonly in glaucoma, especially for congenital glaucoma. However, this is fairly major surgery, which entails conjunctival incision and scleral trapdoor, and is often combined with a trabeculectomy. Ab externo approach to trabecular meshwork in recent times has involved 360-degree catheterization of the Schlemm's canal with devices like the eye-track catheter, and this is facilitated from a single site. However, not many surgeons have explored trabeculotomy as a surgery for glaucoma in adults. Our young adult patient had steroid-induced glaucoma and cataract. Glaucoma was just about controlled with 3 anti-glaucoma medications, and vision was reduced to 20/80. He was advised Cahoop dual blade trabeculotomy with cataract extraction, to which he consented. Cahoop dual blade is a single-use ophthalmic blade which utilizes ab interno approach through a clear corneal micro-incision. Dual blades are positioned for precise parallel incisions of the trabecular meshwork with minimal residual leaflets. The surgical grade stainless steel body is comprised of a long, thin shaft that allows for access across the anterior chamber, a pointed tip used to pierce trabecular meshwork under gonioscopic view, a ram that lifts and stretches the tissue as the device is advanced, and 2 blades to produce simultaneous incisions in treated tissues. Under sterile conditions and topical anesthesia, he underwent a routine lens aspiration surgery through clear corneal incision with foldable implant in the back. Following this, anterior chamber was inflated with viscoelastic, which not only deepens the chamber, but it also facilitates visualization of the angle structure. Patient is asked to look down and slightly nasally, and treatment area is identified approximately 180 degrees away. A direct gonioscope is placed over the cornea to identify the structures in the angle. This is then lifted to aid entry of the Cahoop dual blade in the AC, and the blade tip is placed into Schlemm's canal before advancement. The KDB heel should be seated within the canal of the Schlemm without tilting relative to the distal blade tip. The anterior wall of the canal of Schlemm is visualized behind the KDB as it is advanced to remove trabecular meshwork. Blood reflex is often noted from collector channels after the KDB excises the trabecular meshwork. This trabecular meshwork is then visualized either free floating or attached to the tip of the KDB. Excised trabecular meshwork strips are detached from surrounding tissue by converging cuts into the trabecular meshwork from opposite directions. A minimum of 3 to 4 clock hours of trabecular meshwork in aggregate is excised, about 90 to 120 degrees. Irrigation aspiration is used to remove already free-floating trabecular meshwork strips. Post-operatively, patient was advised antibiotics for 1 week, steroids in a tapering dose, and NSAIDs for a few weeks, and all pre-op anti-glaucoma medications were discontinued. Post-operatively, his eye had minimal inflammation and no hyphema was seen. 1 year post-surgery, he had a visual acuity of 20/20 and N6 best corrected, and an intraocular pressure of 10 mm mercury without medication. Thus, a simple, safe, and elegant technique resulted in favorable outcome for our patient. This conjunctiva sparing, minimally invasive technique for trabeculotomy with Cahoop dual blade can be used as an alternative to bleb forming surgery. However, trabeculectomy can still be performed should it be required in future. Three. Young patient on a beta blocker is not happy. I stand here as a surgeon who believes in minimally invasive surgery. No, that's the problem. It's not available in India. You have to either purchase it. In the West, I got them as samples. So I have managed to use it for my patients. But and it's very easily, the training is also very easily available. It's disposable. But in our scenario, I'm using it twice. Yeah, reusing it.
It's a wonderful video. So, how did you manage, the intraoperative bleed? I mean, how much time it took to complete the surgery?
It did not take long. It's just that when the bleeding stops your view, then you just aspirate the blood, irrigate and aspirate it away, and then you restart from where you left off.
So again, you have to put the lens and then again relocate each area.
Yeah, putting the lens is not a problem. Actually, how it has been explained in the West, that you approach it temporally and do it nasally, that is far more difficult. When I suggested that I sit superiorly and I asked the patient to look down, they said, "Wow, that's wonderful. Why haven't we thought about that before?" It's so much easier. And you don't have to align. I don't know if you've used a direct gonioscope or not, but you have to ask the patient to look in a particular way. You have to tilt the microscope. Many things you have to do. I had to do nothing. Or I have to do nothing.
How many cases have you used?
I've done it for 2 right now. Doing very well. Pressure is controlled.
So would you see yourself using this rather than surgery?
Yes, absolutely. Absolutely. At least as the first step, especially if I'm contemplating cataract surgery and the patient is on several medications. We don't think about medications, we continue with them, but there's question of side effects, there's question of cost, there's question of quality of life, which we are not unfortunately addressing enough. Thank you. Thank you.
Thank you. We had a wonderful video session, and the next session will start in 15 minutes, 10:30. Thank you.
Audio Jungle.